Hello everyone, good morning and good afternoon to our Indian audience. Thank you for joining us today. I am delighted to welcome you all to our scientific webinar on International Molecular EQA for robust assessment of bloodborne viruses. I am Sitilesh Prajapati, product specialist from India. So it is with a great pleasure that I introduce our distinguished speaker for today's webinar, Dr. Dwaine Vance. Dr. Vance brings a wealth of expertise in molecular infectious disease. Dr. Vance has gained his Ph.D. from Queen's University Belfast. His work included investigating the genetic predisposition of autoimmune renal disease, utilizing biotechnologies such as MALDI-TOF and next-generation sequencing. Upon completion of his Ph.D., he has worked with Randox Molecular R&D department, developing multiplex PCR assays for infectious disease. With his rich experience in molecular diagnostics, Dr. Vance is now working as molecular specialist, advocating and educating lab professionals in international molecular EQA schemes, as well as use of third-party whole pathogen molecular controls that helps laboratories to meet ISO 15189 requirements. Also, I wanted to remind everyone that we'll take a question at the end of the presentation. You can type in your queries into the chat box and we'll answer them if possible at the end of the session, or we'll email you your queries. Now, without taking much of the time, over to you, Dr. Vance, for your talk on International Molecular EQA for robust assessment of bloodborne viruses.
Dwayne, sorry, you're on mute.
Okay, Donald, can you confirm you can hear me okay?
Yes, loud and clear, Dwayne. Thanks.
Okay, apologies. I wasn't aware that I was on mute there for a second. So good morning and good afternoon to wherever you're joining. It's a pleasure to provide you all today with a presentation to discuss the benefits of participating in an international molecular EQA for the robust assessment of blood-borne viruses. And as I said, Les, thank you very much for the very kind introduction, and I look forward to presenting and talking to you today about this very important topic. So I will provide you with a brief overview of the presentation here this afternoon. So the presentation will be in two parts. The first part aims to provide a background and to educate the audience on the importance of international EQA participation. It will include the key definitions and comparisons between EQA and IQC, and will also just describe the typical life cycle of a molecular EQA process. The design and the objectives of an EQA will also be discussed. The second part of the presentation will aim to delve a little bit deeper into the inner workings of an international molecular EQA provider, including the report interpretation and the analysis and statistics used to assess the participating laboratories. Finally, at the end, we will highlight the features and benefits of QCMD, a well-known and globally utilized molecular EQA provider that specializes in the provision and supply of molecular EQA schemes for infectious disease testing. So essentially, external quality assessment is an important and integral part of quality assurance within any molecular microbiology lab. This image on the screen highlights the multiple sections required to create an effective and robust quality management system and quality assurance procedure for successful lab accreditation to maintain and improve lab quality. And you will see, as denoted by the yellow star at the bottom of the screen, that EQA is an important aspect of quality assurance. It's only one of many different aspects of quality assurance, and this will be the particular focus of this presentation today. So a few definitions and comparisons before we get into the main aspect of this presentation is to describe the definitions and comparisons between QC and EQA. IQC is to determine the precision of the investigation or molecular workflow, whereas the participation of an EQA is the assessment of accuracy. The main objective of molecular IQC is to ensure the day-to-day consistency of an analytical process and thus help to determine whether patient results are reliable enough to be released. Whereas the EQA assesses the laboratory's ability to use molecular diagnostic technologies within a clinical setting. This is achieved by providing the laboratory with a series of blinded samples that resemble clinically significant specimens. IQC and EQA are complementary, therefore they should be run in conjunction with each other to help provide a complete, robust quality management system. The WHO defines an EQA as a system for objectively checking the laboratory's performance using an external agency or facility. An external agency, which will be referred to as an EQA provider within this presentation, is responsible for the external organisation and coordination of EQA schemes with the aim to improve transparency amongst all of the participating laboratories within that particular scheme. This is in contrast to other interlaboratory comparison methods such as ring studies or ring trials, which are often organised internally between labs without interference of an independent external body. Other definitions of EQA or proficiency testing providers is that described by International Standard 17043. Proficiency testing schemes are interlaboratory comparisons that are organised regularly to assess the performance of analytical laboratories and the competence of the analytical personnel. Whereas the CLSI, their definition of an EQA is a program which samples are periodically sent to participating members of a group of laboratories for analysis and or identification, whereby each laboratory's results are compared with those of other labs within the same group and or with an assigned value and reported to the participating laboratories and others. There are many different reasons why the participation of an international molecular external quality assessment is important. And the first one being that the aim of the EQA is to assess a lab's performance in comparison with the other labs using the same molecular workflow. So if you're using an Abbott or an Hologic platform to assess the detection or the viral load of a particular pathogen, then you want to investigate your lab performance against other labs that are utilising the same method or instrument. Molecular EQA scheme participation provides an effective method of monitoring a lab's performance, but also a lab's bias or accuracy through the analysis of blind samples. And it's important to note that any sample that is processed as part of an EQA must be processed in the laboratory in exactly the same fashion as a patient clinical sample. Participation in a molecular EQA scheme will also support international regulatory requirements and national requirements, as well as improving on quality assurance within that lab. We will explore these regulations in more detail in the subsequent slides. The overarching aim of the EQA is to ultimately periodically assess a lab's performance in comparison to other labs. This is a snippet from the randox.com website outlining the main benefits of participating in a molecular external quality assessment. It enables comparison between labs, enables a comparison between sites, provides an early warning for systematic errors, indicates areas in which the molecular workflow can be improved, provides evidence for quality, which is important when internal and external auditing is taking place. It also helps to identify training areas for staff to improve competency amongst the staff and personnel within the lab. EQA can also help detect equipment faults, identify any issues with the reagents, and it's also a way to review the staff training. It also helps to compare performance to different analytical methods. So in relation to the international regulatory requirements, it's clear that the participation of an EQA is an accreditation requirement as defined by International Standard 17025, 15189, CAP and NABL, to name a few. Moreover, it may be a mandatory requirement with the laboratories to report the results of their EQA to their national body within that particular region. International molecular EQA providers are also required that the EQA schemes that they are assigned, that they enroll, fulfill the requirements of an international standard 17043. In addition to this, ISO 17025 and 15189 recommend that testing and diagnostic laboratories collaborate with EQA providers and utilize their schemes that are accredited to the International Standard 17043. So we're going to delve a little bit deeper into International Standard 15189 2022 edition, which was updated in December last year, which we are now in our 4th edition. And this standard is in regards to lab quality and competence within medical laboratories. And with regards to this standard, I'm going to focus on clause 7373, which relates to external quality assessment. So I'm just going to read out some of the main clauses and how it shows the importance of participating in an external EQA scheme. The lab shall monitor its performance of examination methods by comparison with results of other laboratories. This includes participating in an EQA program appropriate to the examination and interpretation of examination results. The EQA programs selected by the lab shall, to the extent possible, have the effect of checking the pre-examination, examination and post-examination processes, also referred to as pre-analytical, analytical and post-analytical processes, and provide samples that mimic the patient sample for clinically relevant challenges. So the sample must be commutable and should react to the examination system in exactly the same way as the patient sample, but also the samples provided within the challenge of the QA should exist at clinically relevant challenges and be indicative of a clinical scenario. And the participation fulfills the the EQA provider should also fulfill ISO 17043 requirements. When selecting an EQA program for your laboratory, the laboratory should consider the type of target value that is offered. Target values could be independently set by a reference method or alternatively set by consensus data and/or set by a method peer group consensus data or set by a panel of experts. I will provide an example of this from an international molecular EQA service provider that supplies a large number of molecular infectious disease EQA programs globally. EQA data shall be reviewed at regular intervals. So within your lab, how many challenges does your molecular workflow need to be assessed? Is it once per year? Is it twice per year, or is it more than that? Where EQA results fall outside specified acceptability criteria, then appropriate action shall be taken, including an assessment of whether the non-conformance is clinically significant. Where it is determined that the impact is clinically significant, a review of patient results that could have been affected and the need for amendment shall be considered. Okay, so I am going to provide a typical life cycle of the molecular EQA process. And this example is in reference to the QCMD molecular EQA provider and can also be taken from the Randox website. So the first aspect of the life cycle is that participants may register for the EQA programs. And all aspects of the scheme can be easily managed on an online resource called Items. The material is distributors at predetermined frequencies. There is a choice of 1, 2, or 4 distributions per year. The laboratory analyzes each sample as they would exactly a patient sample. The data is collected and returned online to QCMD for analysis. And the EQA reports are sent via this online portal within 2 weeks. However, some programs may take up to 4 weeks. So the EQA providers supply registered labs with blinded, clinically represented samples at predetermined intervals. Labs test these samples using their routine testing methods, and the data analysis is conducted and reports sent. And after this process is completed, a certificate of participation is sent out. So the main EQA design and the EQA objectives of a typical international molecular EQA scheme is that international EQA schemes should be designed in accordance with this very important ISO standard 17043 or in line with CLSI MM14 or other relevant national guidelines. Objectives include to provide an EQA program that contains the most clinically relevant targets detectable by molecular methods, to provide a true measure of individual laboratory performance, to provide information for the monitoring of lab performance to appropriate authorities if required, to provide feedback and continuous education to each of the participating laboratories, to develop new pilot EQA studies, either directly or in conjunction with other EQA providers or a team of international scientific experts, and to provide information to support the laboratory's regulatory requirements and support the laboratory's clinical accreditation process. So I'm going to provide you with This an example of an international molecular EQA provider, QCMD, based in the United Kingdom. QCMD is an independent international external quality assessment provider specializing in molecular testing for a wide range of infectious diseases. Currently, QCMD has an extensive database of over 16,000 participants in over 120 countries. QCMD is one of the largest providers of molecular EQA in the field of molecular diagnostics. So one of the benefits of participating in this in an international molecular EQA is the wide range of participants globally throughout many countries, but also the spectrum of instrumentation, may that be commercial or in-house assays, is very diverse and wide-ranging. This EQA QCMD provide many different blood-borne schemes, and today we'll focus on some of the reports for HIV, hepatitis B, and hepatitis C. But other blood-borne virus schemes are covered within the QCMD portfolio, including dried blood spots, schemes for drug resistance and genotyping, but also hepatitis A, D, and E. There's also an EQA scheme for HIV-1 DNA and also HIV-2 testing. These reports are available as qualitative and or quantitative, so useful for very, very effective to determine your lab's performance in quantification of blood-borne viruses. The aim of the HIV-1 RNA scheme is to assess the proficiency of laboratories in the detection and quantification of the HIV RNA and different HIV genotypes. The HIV scheme exists as 3 different frequency formats, as you will see on the image on the right-hand side. It exists as a single challenge, where 8 panel members are sent out once per year in Q3. It also exists as a double challenge, in which 4 samples are sent out twice per year, 4 samples in Q1 and 4 samples in Q2. And finally, it exists as a 4 challenge program, where 4 challenges are sent out 4 times per year. There is a distribution in Q1, Q2, Q3, and Q4. Each of the vials contain 1.2 mils per vial, and this allows laboratories to submit multiple different data sets. So the only limitation on the number of data sets that you can provide is based on the sample volume that you use for your molecular workflow. So you can submit as many data sets that your molecular workflow allows, up to a total volume of 1.2 mils per sample. The sample matrix is in a plasma, which means that the sample is commutable and will react in the same way as a patient sample. Because this is a quantifiable scheme, international units and copies per mil units are accepted. And importantly, as we have previously mentioned, the importance of ISO 17043 accredited EQA providers. This scheme is accredited to this important international standard. And the 8 samples are clinically representative of clinical scenarios. Therefore, the samples will cover a clinical range, a relevant clinical range. The hepatitis B DNA scheme is very similar to the HIV scheme. The format, the aims are exactly the same: to detect and quantify HBV DNA and different HBV genotypes. The frequency formats are exactly the same as the HIV schemes, and the scheme specifications are also the same. The HIV, hepatitis B, and hepatitis C are often tested together as triple H pathogens, so it would make sense that the format, aims for, and frequencies and scheme specifications are exactly the same. The primary unit of hepatitis B is international units per mil. However, other units will be accepted. The hepatitis C RNA scheme. The aim is to assess the proficiency of the detection and quantification of hepatitis C RNA and its genotypes. The frequency is the same as hepatitis B, 1 challenge, 2 challenge, or 4 challenges per year, up to a total of 8 samples per annum. And the volume of the vial is the same, up to 1.2 ml per vial. And this is a qualitative and quantitative scheme. And again, and importantly, this program is accredited to International Standard 17043. So with regards to the registration deadlines, the single challenge program, the deadline for the single challenge programs for HIV, hepatitis B, and hepatitis C is the 24th of April, and that is distribution cycle number 11, which is distributed globally in Q3 of this year. Now, going into a little bit more about the different report formats that are offered by International Molecular EQA providers. Molecular EQA reports should be easy to understand for each of the participating laboratories. Depending on the objective of the molecular EQA scheme, reports may fall into different categories. For example, some molecular EQA schemes can be qualitative in nature. That could be looking at a single pathogen or multiple targets with, for example, syndromic testing panels. Some reports fall within qualitative and quantitative. That could be a single pathogen such as HIV or hepatitis or multiple targets. There are also molecular typing reports, sequencing reports, gene typing reports, and non-molecular typing reports such as MALDI-TOF, a MALDI-TOF scheme for bacterial and fungal identification, which is also included within the QCMD portfolio. This is an example of a panel composition that one may typically receive. This example that I have shown on the screen is an example for HIV RNA. And you will see within this panel, there are 8 samples per challenge. The samples that have been selected are to robustly assess both the clinical and the analytical aspects of the laboratory's molecular workflow. It is important to note that samples selected are both educational and regulatory in nature. Samples can be defined as core samples or educational. The samples selected aim to simulate the relevant properties of samples used within a clinical setting to ensure sample commutability. So as you will see in the table to the left-hand side, there are multiple different types of the HIV-1 virus. There's type B, type C, and type AG, as well as a negative sample. And all of these samples are provided within a commutable plasma matrix. The fourth column you will see is sample relationships, and this shows you the dilution series of those samples. So you will see that sample 3 is a dilution of sample 2, and sample 4 is a dilution of sample 3. And what you will also see is there is the inclusion of a duplicate sample, and this duplicate sample can help assess reproducibility, not only within the same scheme, but across different schemes in different years. So you will see that sample 3 and sample 7 are duplicate samples. These samples have all been defined as core samples, which means that these samples must be detected correctly and will form part of your assessment criteria. The last two columns will show you the quantitative values, the consensus quantitative values that have been submitted by all the peer groups. And then for HIV, the most common unit that has been submitted is copies per mil, with some laboratories also submitting data in international units per mil. So the report can be personalized depending on the units that you have submitted via the online portal. So, as I said, some of the samples may be designated as core proficiency samples based on scientific information, the clinical relevance of that sample, or from data that has been collected from previous EQA schemes. Each participating laboratory is expected to correctly analyse and report the core samples to show acceptable proficiency. However, some samples may be designated as educational. It is important to note that these samples are not included in the statistical analysis or performance scoring criteria. Educational samples may be introduced into challenges to assess characteristic parameters such as limit of detection or the detection of less common strains. Educational may, in time, be upgraded, if you like, to core samples. So in relation to the qualitative reports and how the performance scoring is conducted, this is based on a detection frequency. And the detection frequency is based on peer group consensus of all of the results returned from all of the EQA participants within that study. So what I mean by that is that if more than 95% of people, of participating labs, of data sets, has correctly detected a positive sample, then this sample is determined as frequently detected. If between 65 and 95% of data sets successfully record a positive result for a positive sample, then this is determined as a detected frequency. However, if less than 65% of data sets only record a positive result for a positive sample, then this sample is determined as an infrequently detected sample. And with regards to negative, a panel sample that does not contain the target and produces non-equivocal negative result. So this individual scores for each sample for each individual lab can range between 0, which means highly satisfactory, to a maximum penalty point of 3, which is highly unsatisfactory. And this table here shows you, and colour has been added as a visual aid, that the 0 in this instance is a perfect score, whereas 3 is the least successful scoring for each sample. The HIV report is qualitative and quantitative, so it will provide you a qualitative chart for each sample as well as a quantitative chart for each sample, either using copies per mil or international units per mil, depending on which unit was submitted in the dataset. So the image to the left shows an example of the breakdown of qualitative results across the main commercial assays used to test for HIV-1 RNA. All peer groups are combined and located at the top of the chart, with individual manufactured analysed separately and showing as peer groups below the subheading commercial. Relatively speaking, for this particular sample, which is sample 8, one manufacturer is performing less well. So labs can use this information to identify potential systematic errors within their molecular workflow. For example, maintenance records of machines, staff training, or even how the reagents are stored. And it allows labs to identify any non-conformances, but also to introduce any corrective actions that they may have identified by participating in an external quality assurance program. So with regards to quantitative assessment, for many quantitative EQA schemes, performance is based on the consensus mean of results returned by all labs. Once the outlier values have been identified statistically and removed, and such statistical examples could be the application of the Grubbs test. In addition to this, the consensus mean of the test method and our technology or instrument peer group can be assessed. So what is the consensus mean overall with regards to commercial assessment or in-house PCR tests? And what does the consensus mean within your particular peer group based on the method that you have used? The mean and standard deviation are calculated accordingly, and the sample performance score is based on the distance that the individual sample within that lab is from the consensus mean, and that is shown using this normal distribution curve. So 0 points are awarded for each sample if the result is within 1 standard deviation. If the consensus mean falls within ±2 standard deviation, then 1 point is provided. If the result falls outside within +2 to -3 standard deviations, then 2 penalty points are awarded. And the worst case scenario that if the consensus mean falls outside of 3 standard deviations, then the maximum penalty points of 3 points are awarded for this particular sample. And what does this look like in the actual report that is generated by QCMD and is sent out to all participating laboratories? So on the right hand side, you will see this particular data set, which has got over 200 data sets submitted for copies per mil. And there are a number of different commercial manufacturers that have been included in this assessment: Abbott, Cepheid, Hologic, QIAGEN, Roche, and Siemens. You will see the yellow diamonds on the right-hand side. Those yellow diamonds are indicative to the consensus mean for each of those manufacturers. And then you will also see the presence of a black circle. This black circle is the individual laboratory result. So how close is the black circle to the yellow diamond? And this provides you with a very good example of peer group assessment for the Abbott real-time PCR reagent, where the laboratory's mean falls very closely to the consensus mean. So the value here, it shows that the laboratory performance for this particular sample, which is sample 1, HIV type 1b, in the HIV RNA scheme, is sufficient. Is sufficient at quantifying an accurate value. So a little bit more about the data analysis and statistics process in developing a molecular EQA program. The data analysis techniques are based on approved procedures that have been developed in accordance with this key international standard for EQA, and that again is 17043. The standard procedures have been followed to safeguard the integrity of the entire data analysis process. And this is something that's extremely important for international EQA providers. The statistical design requirements for each EQA scheme are defined in conjunction with the advisor to a specialist in bioinformatics and statistics. And any potential changes to these statistical evaluations and processes are made through an expert committee or executive group before the implementation of any statistical changes. And for full traceability and transparency, all statistical methods are documented, managed, and maintained through a quality management system in line with the relevant international standards. And the reporting of results, each participating laboratory has a unique online profile that is accessible via the internet. In relation to QCMD, the software is called items account, and multiple users within the same lab can access the same account with varying degrees of permissions and authorizations. For example, a lab technician, quality manager, or full access and full authorization may be given to the overall laboratory director. Participants have a defined period within which to test and report their EQA results back to the EQA provider. Typically, this is up to 3 to 4 weeks. The individual report is then made available via this online web portal, and typically this takes about 2 weeks for qualitative and quantitative programs, but up to 4 weeks for any program that is used to assess drug resistance or sequencing results. So, in conclusion, the overall benefits to participating in an international, there are many different reasons why we advocate participating in an international molecular EQA. Not only is the peer group size larger, which improves statistical validity, but it also allows labs to ensure that they're providing customers such as physicians, patients, and health authorities that they can produce robust and reliable results. So the features of QCMD, to finish off the presentation, is that QCMD provides schemes with frequent reporting. Programs are available in various formats, single, double, or 4 challenges per year, allowing the early identification of workflow errors and implementation of any necessary corrective actions. Peer group comparison reports are available within 2 to 4 weeks of the submission deadline. Corrective action can there be initiated earlier, and this is a comparison with other EQA service providers that may take a much longer time period. All the samples provided by QCMD are high quality and pre-characterized, free from any interfering preservatives and stabilizers. There is a commutable sample matrix designed to mimic the performance of a true clinical patient sample. The EQA schemes contain core samples spanning clinically important concentrations with the inclusion of educational samples. The schemes provided by QCMD are accredited to International Standard 17043, and the programs are accepted by many national accreditation bodies around the world. Participant certificates are provided as evidence of participation in a reputable EQA scheme, and the presence of an independent scientific advisory board within the QCMD organisation ensures strict professional conduct. So thank you all for taking the time out of your day to participate in this educational webinar on the importance of participating in an international molecular EQA. And I hope you know a little bit more about QCMD and how QCMD can offer high quality external quality assurance schemes for the robust assessment of PCR assays for infectious diseases, and in particular for blood-borne viruses, for HIV RNA, for hepatitis B and hepatitis C. So thank you for listening, and Sitilesh, thank you very much for organising this presentation for your clients.